Well, good afternoon, everybody. It's my pleasure to introduce Jane Rylett, who's journeyed all the way from London, Ontario, to speak to us on aging, which most of us do know exists, and what can be done about it, which most of us would like to know more about. Jane is the scientific director of the Canadian Institutes of Health Research Institute for Aging. This institute includes scientists from all over Canada who are committed to investigating both aging and how those who experience it can live healthier lives and have a better quality of life. Jane is overwhelmingly well qualified to lead this institute. She has had a highly successful and impressive career in research and administration. In her graduate work on nerve cells and pharmacology at the University of Western Ontario, she was involved in new drug trials in patients with Alzheimer's disease. This kindled her interest and drew her into research on changes in nerve cell function during aging, including effects of neurodegenerative disease. After postdoctoral training at University College London and the Max Planck Institute for Biophysical Chemistry in Göttingen, Germany, she returned to the University of Western Ontario as the Rubinoff Scholar in Geriatrics. In tandem with becoming an established researcher and faculty member, she was progressively and inexorably recruited into senior administrative positions, including director of the graduate program in neuroscience, chair of the Department of Physiology and Pharmacology, associate dean in the Schulich School of Medicine and Dentistry, and co-director of the Molecular Brain Research Group at the Robarts Research Institute. Her achievements in research and administration have been recognized by a number of earned awards, most recently, Distinguished University Professor of Western University, Fellow of the Canadian Academy of Health Scientists, Queen Elizabeth II Golden Jubilee Medal. Through her research, Jane has been active over the years in provincial and national Alzheimer's societies. Now, in her role as scientific director of the Institute for Aging, she has the opportunity to connect research on aging with applications beneficial to those who must cope with its effects, both mental and physical. Today's audience, it seems to me, is tailor-made to receive the message. Here in Senior College, there is an ideal collection of aging brains. What could be more appropriate? I recall the words of the poet Tennyson. And though we are not now that strength which in old days moved earth and heaven, that which we are, one equal temper of heroic hearts, made weak by time and fate, but strong in will, to strive, to seek, to find, and not to yield. So welcome to Senior College, Jane, and the floor is yours.
Well, thanks so much, Harold. That was a lengthy introduction. You promised me 3 minutes, and I think you exceeded it. So, okay, I'm absolutely honored to be able to speak with you today and to be invited to come to Senior College. We have a similar group at the University of Western Ontario, and I've spoken there before. And I must say it's been a highlight during my time at Western to be able to speak to the group. I think I've done it twice now because of the engagement and the questions and the interests that everyone has. So I'm hoping that you'll be interested in this topic today. I'm aging along with everyone here, and well past my normal retirement date as well. So, but still working for the next few years. What I want to talk about is I want to set up a problem that exists right now. And part of that will relate obviously to aging. And then I want to talk about the Canadian population demographics. And I'm going to then weave into it some of the work that we're doing at the Canadian Institutes of Health Research Institute of Aging. I'm not going to talk about any science or any of the projects we're doing, but I'm going to talk about the areas that we have identified as critical need. And this came through our strategic planning process, as well as a lot of outreach that I do with groups across the country. And then sum up basically where I think some of the research needs to go to address problems in the coming years. So right now, 2024, 21st century, we've got two very pressing public health challenges at the same time. It's not enough that we've got a rapidly aging population, but we also have climate change, global climate change. So these are two huge global problems that exist, and they exist together. And so when we look at the future of humanity going forward, it's going to be both warmer and it's going to be older. And all we need to do is look outside on January 31st and there's no snow. It's going to be 6 degrees in a couple of days, and none of us need our winter coats hardly. So I think that we really have to be able to address these two things together. So there's one of the problems, and I'm just going to put this forward as a for debate and discussion, I think, and to look at the conflict between it, is that the goals of the climate change activists and the goals of the aging science researchers or the geroscience community are in conflict with one another for some reason at the moment. So aging and climate change are intricately connected. Older persons are without doubt at the highest risk for health and economic harms from climate change. So if you think about the health impacts of climate change, certainly older persons are most at risk. So breathing problems, heart problems, inability to move around well, all of this is going to increasingly impact the health of older persons. At the same time, the health of the environment, the place we inhabit, planetary health, influences both the aging process as well as what I'm going to call health span. And I'll come back to this word health span in just a moment. So it's becoming apparent in the scientific literature that people are aging perhaps more rapidly and may continue to age more rapidly because of climate change. So climate change is having a negative impact and making us age more rapidly, maybe because we're not moving about as much, maybe if the climate's hot, maybe because the air we breathe. And this is having an impact on what's called health span. So if we think about our lifespan, our health span goes somewhere towards our lifespan. It doesn't pass our lifespan. So our health span is a healthy part of our life. And then there's a part of our life when we're probably not quite so healthy. And then there's the end of our lifespan. So what I'm going to talk about is increasing the health span to come close to lifespan so that we spend very little time near the ends of our life where we're not as healthy, where we have more chronic conditions that are not manageable. So I'm going to talk about health span. So we know that climate change is affecting aging, it's affecting health span, decreasing our health span. And then there is a whole issue around aging science. So we want to understand as aging researchers or researchers on aging, we're all aging, researchers on aging, we want to understand what is it that causes us to age, and how can we slow down the aging process so we don't get so many chronic conditions as we get older? So how do we change the rate of aging? This is important for not only us, but it's important for future generations. But one of the problems that's happening is there's a conflict that's set up at the moment, and you'll probably see that some of this in the popular press and the newspapers and wherever, that some climate activists think that the older population basically is a burden, and because it costs a lot of money to maintain the health of older people. And so they want to stop aging research and they want to just look at youth. And so the problem then is it reasonable to continue doing research on aging to try to promote how well we age in a time of climate change? So this is the dichotomy, and it's causing a lot of problems with ageism at the moment. So the risk then is that science for healthy aging is becoming marginalized. There's more ageism associated with it. And there's a fear that there could be a larger number of older people. And we know that the population is aging. So that brings us to, I just want to spend one moment talking about geroscience. This is the science of looking at how aging occurs. So it's an interdisciplinary field that looks at how aging occurs and the chronic conditions that are associated with aging. So we all know about heart disease. We all know about lung disease, musculoskeletal disease, arthritis, and dementia, for example. So this is the science that looks at how does aging occur and how can we help understand aging and reduce the impact of chronic conditions during aging to increase our health span. So it's an integrative type of discipline, and it's important to look at the risk factors that are associated with this to be able to cut down on the impact of chronic conditions. It's also a translational type of science that basically is looking for prevention strategies. So we all hear that it would be good to exercise, have a great diet, to be able to stay socially active and engaged, to be able to live out in green spaces. So this is all a big part of understanding the mechanisms of how that keeps us healthy. It also helps us understand how we prevent chronic conditions and increase this health span. So it comes very close to the end of our lifespan. So basically what I'm saying here then is that we want to pursue a strategy to control the warming climate and the aging world and bring these two things together in a way that helps not just us, but also the generations that are yet to come. So that's kind of where we're at in Canada and the world in 2024. So let's look now at the Canadian population. We always keep hearing that the Canadian population is aging, and I'm always really surprised when I actually look at the numbers, because the rate of change and the rate of aging of the population is quite considerable. So the baby boomers, many of us, most of us in this room, in fact, maybe all of us in this room, are baby boomers. So the first baby boomers turned age 65 in the year 2011. At that time, the number of people in Canada, this is just Canadian data, was 4.9 million. So just under 5 million people were age 65 or older. There were about 650,000 people between 85 and 99, and there were about 6,000 people over the age of 100 at that time. Now let's move forward another decade. So 2 years ago in 2022, so these aren't even up-to-date numbers. So now the first baby boomers turned 76 that year. Look at this increase in the number of people just in one decade. 4.9 million people over the age of 65. Now it's up to over 7.3 million. So the considerably more people over the age of 65. The number of people in the longest living group, the 85 to 99 group, went from under 650,000 to now almost 870,000. And more than twice as many people over the age of 100. So 6,000 up to 13,500. So you can really see how the population is aging. And then if we go to 2041, so whatever, I can't do the math, it's under 20 years from now. So like whatever it is, 18 years from now, somebody can do the math. So now when we look at this, now the first baby boomers are turning 95. The 85 years and older, the longest living older adults that are the fastest growing segment of the population now are even picking up greater pace. And I'm going to show you a graph of this in a moment. What's different now is that the number of new Canadians, immigrants to Canada, is now up to about 34%. In 2016, only 8 years ago, it was 22%. So we can see there's a large influx of persons, and this includes people in the older adult population as well. I think one thing that's really important about the population as we look forward, and I think we all know this, is that it's becoming increasingly diverse. And in Toronto, it's a hugely multicultural city. We know that the way we approach social interaction, the way we approach services and thoughts around aging is we have to look at what's culturally appropriate, and culturally appropriate approaches towards aging and health. And so there's a large increase in new Canadians, and including in the older population. So I'm going to show you this picture. And what this does is take those numbers that I just told you about and puts them into a picture. So this blue or turquoisey color here basically is the census, the Canadian census from 1971. And here's the baby boomers. Down here, they're 10, 15, 20 years old. So you've got this big bulge, and we've always heard about the bulge of the baby boomers in the population. And you can see how few people there were just back in 1971, not that long ago. You can see how few people there were in this, 75, 70, 80-year-old group, and certainly not up around 100, very few. Then this purple line that is drawn in around here is the census data from the year 2000. Now you can see this baby boomer bulge has moved up. And if we go across there, now the baby boomers are in their 50s, or in that sort of few decades around 50, 60 in there. So you can see how that's moved up. Now, 2021, so 3 years ago, the most recent census data for Canada, you can see how the baby boomer bulge has moved up. And now what you see is this huge difference here in the 60 and over age group. Look at how many more people there are in this age group. So we can see the change in the Canadian population demographic. But the other thing that you'll see here, see this, and if you can follow this dot, red dot that I have going around here. If you see this bulge here, so these are the baby boomers coming up here, and they're marching along and heading towards 80s, 90s, 100. But now there's this other bulge here, and these are new Canadians. And so whereas we thought a few years ago, I'm thinking back even 20 years ago, we thought the baby boomers are going to age out, go through the population, and then there's going to be normalization within the Canadian population. That's not what's happened at all. We have huge immigration in Canada. So now we've got a big bulge coming behind that are now in their, averaging out in their 40s or 50s. And so now that means that Canadian society is going to have this large bulk of older persons continuing to be fed in. And then to go along with that, the fertility rate in Canada is very low. There's not even replacement now. So it's not, it's not one baby for one person. It's actually less than that. So now we have a very short part of the pyramid here, and then this very large part going up. And because of immigration, it's feeding it up even more. So that's what we're looking at. And I mentioned that the 85 and older group, often called the oldest old or the longest living older adults, this is the fastest growing part of our population. So this is the percentage growth. So right now, the growth of that age segment is around, say, 15, 16% every year. It increases by that much. But when we get out here to like 2030, for example, it's going to be going up 30, 35%. And so there's going to, within the next 2 decades or 3 decades, there's going to be a huge push and much, much larger group of people in the 80, 85 and over category, and centenarians in particular. What's the demographic within that? Well, predominantly women. If you look at the centenarians, at least 80% of centenarians are women. So they live longer. Okay, so what's the other part of this? Well, the other part of this is what I just said, that the birth rate is very flat and in fact decreasing. So back in about 2016, the lines for the growth of population of persons age 65 and older was going up. Go back here to 1951. It was, you know, way down here. And over those intervening decades, look how it grew. The number of children 14 and under stayed relatively flat, and it's actually probably going down from that. So in 2016, there were the same number of people over 65 as there were children 14 and under. Now that's separating. So now the number of people over age 65 is greater than the number of people 14 and under. And this gap is going to continue to widen as we go forward. That's okay. One thing that we know is that Canada is way ahead of other countries. So I didn't put the data here, but I have world data and I have US data on this. We're way ahead. The US, in the United States, this line hasn't crossed yet, because the lifespan in the United States is actually less than it is in Canada by 2, 3, 4 years. And then if you look at world data, these lines don't cross until something like 2040. So Canada is way ahead. And I guess one point that I didn't make on this slide back here is that right now, or at least in 2021, so going back a few years, 19% of the Canadian population is age 65 and older. We're now at about 20%. And the World Health Organization definition is that we are now a super aged country. So we are in a real minority. Japan was the lead, Germany's there, Canada is there. So we're distinguished, but that brings its own issues with it. So, and some of those issues are right here. So the impact then of fewer young people, lots and lots more older people, is a huge impact on our health and care systems, huge impact on housing, and huge impact on social services. And so I'm going to speak in just a few minutes about the healthcare system and housing. So that's where I'm going. Okay, so just a few more stats, and these come from Statistics Canada. In life expectancy in Canada, look at how these numbers change. I'm staggered every time I look at these numbers. So the life expectancy in Canada in 1961, and we all remember 1961, was 71 years old. 2015, which is almost 10 years ago, the life expectancy was 82. Now the life expectancy in Canada is just over 84. Okay. Something that we really need to think about is the disparity within Canada. And this is something I think about a lot, because I have to think about different communities, different cultural communities. If we look in Indigenous peoples, and these are numbers from Nunavut, for example, life expectancy is 72 years. So a real cultural disparity in Canada. Now here, let's look at the OECD. These are the international data. So here we have men versus women, and we all know that women live longer than men. So the longest lived country in the OECD, and this is Japan, men, the life expectancy at birth is 81.6 years, women 87.3. Canada, by comparison, men 80, women 84.1. And this is old data from almost 10 years ago. So it is greater than that now. I think women right now in Canada is over 85. Interestingly, the United States is much less than that. The life expectancy, this number here in the United States is down around 76. So we're quite a bit, and you know, you can think of reasons why that may be. The other disparity that we need to think about, and that I think about a lot, is the difference between people by socioeconomic status. So higher socioeconomic status in Canada have these life expectancies that we've seen over here. If you look at people in poorer neighborhoods or lower socioeconomic status, you can see that there are years difference, 4 years difference in life expectancy for men, two for women. So lots of things that we need to think about when we think about social services, healthcare delivery, housing, all of the critical things that are needed for health and well-being of older persons. Okay, so where do I want to go with this now? So as Harold mentioned, I'm the scientific director of the Canadian Institutes of Health Research Institute of Aging. The Canadian Institutes of Health Research, or CIHR, is the federal grant funding agency for health in Canada. So we fund all of the health research. We report through to the Minister of Health. And we fund everything from, you know, very mechanistic cellular molecular disease-oriented research to understand disease and well-being, to clinical studies, to population health and health services. And so there are 13 institutes, and one of them is aging. And we just produced our new strategic plan just this past year, and we've named it Reframing Aging, Empowering Older Adults, because with the number of older adults that we have in Canada, empowering older adults and finding health and reframing what it means to be old in Canada is really critical. So there's a huge problem with ageism. I set up the presentation by talking about the problem associated with ageism because of tensions between climate change activists and the anti-science, health aging science. So there's ageism throughout, permeates the system, not just with climate change, it permeates other parts of our lives. And so we need to be able to reframe aging so that society understands what it means to be an older person, what the needs of an older person are, and how we can coexist and provide meaningful lives for everyone across the life cycle, the age spectrum. Okay, so the subtext of this is to have research and promote research. We fund research. So research to achieve equitable health and aging. So part of this reframing aging, empowering older adults is really around reframing, restating, understanding what the health goals of older people are and what living well means. And that living well doesn't mean that we're living disease-free or that we don't have, you know, aches and you know, all kinds of things happening. It means living well with what we have. So we've got chronic conditions. Dare I say, probably most of us in this room have chronic conditions, and it's living well with them, managing them, understanding them, and having the resources we need to live well. So striving to promote and support healthy lives, and in particular, increasing resilience. So when something happens, having the resilience to be able to overcome that and to be able to then move on and move forward. So framing aging in positive terms, not just for the older population, but for younger people as well. And so the whole intergenerational system within the country understands aging and values aging. And so basically it's to look at the impact of well-being and aging. So part of this comes from work of the World Health Organization. So we are midway through the decade of healthy aging. That the World Health Organization and the United Nations put forward. And so they define healthy aging as a process of developing and maintaining functional ability that enables well-being in older age. I think that's a good definition. They then break it down into two things: intrinsic capacity, so our ability to be mobile, to think, to sense things, to have mental health and wellness, and vitality. So that's our intrinsic capacity to be able to live. And then functional ability is the capability that enables people to do what they value most. So even though you might have problems with elements of your intrinsic capacity, you can still have great functional ability and capability to do what you value most. So this then encompasses a lot of things, and I'm going to only focus on two of them. So optimal aging is the goal, living well and doing well with what we've been given. But some of the challenges are access to healthcare, housing insecurity, isolation, loneliness, and ageism, decreased workforce because there are many fewer young people, and then climate change. But there are a number of ways that we are working towards finding solutions to some of these within the Canadian context, and that's important, that it's within the Canadian context. So looking at age-friendly built environments and accessible transportation, looking at programs that enhance social participation and community support and autonomy. And I dare say that being here at the senior college is actually part and parcel of all of that social participation. The decreased workforce actually gives an opportunity for older persons. Yes, of course, at some point we want to, exit the workforce, but there are lots of ways to remain engaged, to engage in volunteer activity, and may even be intergenerational activities, which helps younger people understand the value system for older people. Then I mentioned geroscience at the beginning. So if we look at climate change, we have to understand how the climate is impacting us as we age, understand what aging is about, and then promote health across the life course. Okay, so these are all the things that we're working on at the CIHR Institute of Aging. I'm not going to go through them all, obviously. There are three that I'm going to go through, and I'm going to come to each of these three things individually. So the first one is around implementing prevention strategies and promoting health and well-being in aging. So by looking at this, we're reframing aging in Canada to envision the future of the health span. So remember, I talked about the health span is the time that we're healthy. And then at the end of that, there's a time when we may be less healthy before the end of our lives. So we want to envision what the health span is and work at increasing the health span. And that includes quality of life. And we want to move the health span as far as we can towards the end of the lifespan. It'd be great if they were the same thing, but that's a lot to hope for. Okay, so how are we going about this? Well, we need to understand better about the heterogeneity of older persons. And I'm going to come to that in the next slide, so I won't define it now, but that involves geroscience as well. We want to mitigate the risk related with development and progression of chronic conditions. That's all part of understanding what aging is, aging and health. And then we want to focus on wellness and quality of life to maintain optimal health and, importantly, independence during life. So let's just look at a little bit of this. So heterogeneity of older persons. It's really important to realize that, when do we say somebody's an older person? I don't know. Is it 50? Is it 60? Is it 70? I don't know when it is. And different people will feel older at different times. Some at a much younger age than others. But for many people, the phase of being an older person can span at least 4 decades, between 50 and 90, between 60 and 100, given where our lifespan is at the moment. But not everybody is the same. And so if you think about somebody's chronological age, it may not be the same as their biological age. So you could have a person that's 80 and a person that's 65. And that 80-year-old person could be much healthier and more vital and going out and doing more things than that person that's 65. And that may depend on their life challenges and their chronic conditions as well. So you can't look just at somebody's years, their number of birthdays. You have to look at their biological age. And so one of the things that we're looking at is trying to understand how we can categorize people or at least look at people and provide help to people by their biological age and give them what they need for a good life as opposed to what their actual number is. And so part of this is when we look at information that comes from the Public Health Agency, and I'm sorry, you probably won't be able to see all of this. I'm certainly happy to give you the slides afterwards. But what this says is that at age 65, at least 3/4 of people have at least one chronic condition. That could be high blood pressure, it could be periodontal disease, it could be arthritis or diabetes, there's any number of things. So at age 65, 3/4 of people have at least one. But if you go to the age 85, now 3/4 have at least three of those things. So they may have periodontitis, they may have heart disease, and they may be diabetic. So, or they may have arthritis, any of those sorts of things. So it's important when the healthcare system looks at individuals, they understand this and not their chronological age. And so just because somebody's 80 doesn't mean they are necessarily near the end of life and in poor health, because they may be much healthier than somebody who's a couple of decades younger. Okay, so the second part of our strategic plan then is adapting health and care systems to better understand or address the needs of older persons. So older persons require evidence-informed health care and services that are both age-appropriate, culturally safe, accessible, and grounded in equity. So we are working towards funding research on equitable health and care systems that are geared towards older persons. And that's what I want to talk about for just 1 second here. Okay. So when we look at the Canadian demographics, again, I'm coming back to that, the care needs have changed dramatically. So in 1966, the median age in Canada was 25.5. And now in 2017, which is still almost a decade ago, is 40.6. So you can see this population aging. But one of the problems is hospitals have always been designed to serve younger people and younger people with acute medical needs. Hospitals are not then or not now designed to meet the needs of older people. And so the healthcare workforce is also not equipped to meet the needs of older people. So exactly, 2019, so a few years ago, not many years ago, there were almost 3,000 pediatricians in Canada, 304 geriatricians. That's 10 times more pediatricians than geriatricians. What's happening in our population? It's going like this. Many fewer young people than older people. We saw how those lines moved apart. And if you look, for example, in just about any reasonable sized city, they're going to have a pediatric hospital and a pediatric emergency ward. And if you look anywhere except one, I know of only one, UHN here in Toronto, has a geriatric service in the emergency ward. That doesn't mean there aren't geriatricians around, but they have a specifically designed emergency department for geriatrics. That hasn't spread across the country. That has to change. And so these are some of the things that we're promoting and providing research funds towards implementation science and evaluation sciences. So, and the other problem, of course, and we hear about this all the time in the news, is that it's very difficult to get primary medical care. So very large shortage of primary care physicians. And these are the numbers that I came up with. 1 in 5 Canadians, or 6.5 million Canadian people, don't have a family physician, and that may be more than that. Okay, so what has to be done in this area? Well, the critical priority needs in health care and services to meet the needs of the older Canadian population is development of indicators, and this has to progress over time. So there needs to be an increase in primary health care, with access and continuity of care that's relative and relevant to older persons. The healthcare workforce needs to be adapted to meet the needs of older persons. So we've funded research programs just within the last year on this to be able to promote training programs for healthcare workforce for increases in geriatric care and care for older persons. There has to be an absolute modernization and reform of the health and care systems to be able to meet the needs of older persons and develop increased resilience in the healthcare system. We all know what happened during the pandemic in the healthcare system, and certainly we don't want a repeat of that if there's a second pandemic, and undoubtedly at some point there will be, but what lessons are learned and how can that be fixed, and how do we adapt the healthcare system for older people? So that's a huge topic, and obviously something that we have to be passionate about. And then the healthcare system also has to be equitable and decrease the fragmentation. So there has to be good transitions and continuity of care as patients move through the system. So we're obviously working towards more patient-centered and integrated care teams and equity in delivery and access. So now the third area, and I'm getting near the end now. So improving lived and living experiences and quality of care in the later years. And so this includes at end of life as well. And the important point here is that we recognize the rights to self-determination as a vital part of health and well-being throughout the later years. And if we think back to the pandemic, we see what happened there with people that were in care homes, long-term care, were not allowed to see their family. Their family couldn't come in. They had other forms of neglect and were not able to have those decisions themselves. So they lost the right to self-determination and agency during the pandemic. And so this is an area that there needs to be a huge change so that even near the end of life, people have a right to self-determination and decision-making. So this is really around respecting older persons' lived and living experience. It also speaks to where people can live. So not just aging in place. We often hear about aging in place. People want to age in place in their homes. It's all about aging in the right place, because aging in the home isn't necessarily the right place for a lot of people. And so this is another area that we're doing a lot of work. So most older Canadians actually live in their home or in the community. So we often have this concept that a lot of older adults live in long-term care. That's not at all true. Only about 7% of older Canadians actually live in long-term care. The vast majority continue to live in their homes or their community or some sort of supportive living environment. And most want to be able to live in those environments. But it has to be with the right kind of support. It has to be the right place, not just aging in place. And so we know that there is a severe shortage of housing for older persons. There's a real crisis in housing in general right now in Canada. We're hearing lots and lots of that in the press, and the politicians are going at one another at a great rate around the whole thing. But you don't hear a lot about the needs for older persons. And so part of this is due to the increasing number of older persons, but also the low property vacancy rate and supply and soaring rental costs. And when you look at particularly the oldest part of our population, predominantly women, often limited incomes and inability to be able to make the choices around the kind of housing they want. So many older women are living alone, have low incomes, and are not having their core housing needs met. So when we think about meeting the housing needs of older persons, we have to be able to think about what independent living looks like, provide income supports, affordable housing, and transportation and access to green spaces is absolutely critical. We also have to address the issues around social isolation and loneliness. I have, so at my, my CIHR Institute, I have an older adults advisory council. And I don't think there's anybody here that's on that council, but there are people certainly in Toronto that are on it. And they serve as an opportunity for me to hear from people across the country, including the North, about what the life is like for older people in those regions, and what some of the needs are. And we talk a lot about housing. And so this is where the whole notion around how aging in the right place comes. And I've had various people on my older adults advisory council talk to me about the fact that loneliness is having such an impact on their friends and even on some of them, because they're not able to make social contact in the housing setting that they're in. And they need to be out of that housing setting and in some other kind of setting where they're getting more care and more social interaction. So that's an area that we're actually funding a lot of new research in at the moment. And then it's also around looking at more imaginative ways for designing housing and designing transportation for older persons. So investing in housing, looking at different forms of living arrangement and transportation. And so one of the things that I've been having a lot of communication with people about right now are so-called NORCs, naturally occurring retirement communities. Is there anybody here that lives in a NORC? Do you know if you live in a NORC? No? So, okay, you live in your home. What NORCs? So this is super interesting. These are older persons coming together saying, I love my home. I want to live in a home. I certainly don't want to be in this supportive living, but I need some help. And people coming together and saying, okay, fine, we're going to develop a community. And there's a lot of this on the West Coast, some on the East Coast, and there's a number in the Toronto area, north of Toronto, other places too, but those are the three hot spots in the country. And I've heard presentations from NORC developers who are older persons. So they form a community, hire in the services they need, so are living independently in homes. It may even be an apartment building. Some of them are even apartment buildings. So you have your suite in the apartment building, but there are services available. So it's like it forms a community. So there'll be more of this happening. And I think this is a great way for sharing costs and for developing communities. And they're not necessarily just older persons that are in these. Some of them are intergenerational. Some of them have younger people as well. And then the other part are age-friendly and dementia-friendly communities. And we know there's a number of great ones starting up in Canada. Okay, so I'm basically at the end. So let's sum this up. So this is really around developing a framework based on the unique needs of the older population and what the ultimate goals are to ensure well-being and health. And so some of the things that we are looking at and funding at the CIHR Institute of Aging, and the research that we're putting priority on is in the area of healthcare and health system transformation. Absolutely huge. We need this for the older population. Why do we have 10 times more pediatricians than we have geriatricians? Why do we have pediatric emergency rooms and pediatric hospitals when we don't have a parallel system for this large older population? It has to also be learning health systems. So it's constantly quality improvement and learning as we go. Also, research and mitigation of ageism. Ageism is throughout the community. You run into it often. I was at the hospital a couple of weeks ago with my husband, who's about 10 years older than I am. He has gray hair. Fortunately, I never developed it. I don't know why. Anyway, we're there. He's there for an appointment. He has to have a follow-up appointment. And so the individual who was booking the appointment looks to me and speaks to me saying, oh, can he come at this time? I said, I don't know. He's standing here. Ask him. And the individual persisted in speaking to me. He's 10 years older than I am. I maybe look a little younger than I actually am. And that was ageism. Speak to the person. So it's there, and we have to overcome it. We have to help Canadian society understand about aging, understand the value of the older person, and what we all have to gain by living together. Sound like I'm on my soapbox, don't I? Advances in communities, housing, and transportation. I just talked about that. Equity and health outcomes across the life course. And this is an area I haven't talked about, but the approach that we are taking, and I'm working very closely with the scientific director of the CIHR Institute of Human Development, Child and Youth Health, and we're looking at health across the life course. And this is particularly important when you think about climate change, because the impact on younger people right now from climate change is going to only be worse when they're older, because it's impacting aging, it's impacting health span. So we have to be able to look at this across the life course. And then the issue I said about health span, assessing where health span is relative to lifespan, so that we can lengthen health span, the length of time that we're healthy as we're aging, and then have a short time at the end where we have more health challenges. So not having this long challenge of health, but increasing aging. And so we have to understand what underlies aging biology, not to increase lifespan, but to just increase health span, and away we go. So the last thing I'm going to show is this cartoon, and you can't read it. I know it's really fuzzy. This comes from a colleague of mine, whose name is Colin Farrelly. He's at Queen's University in the political science department, but he's actually a philosopher. And he writes a lot about ageism and health and aging and climate change as well. And so he put this quote from Herder about imagination and idealism in medical sciences. And so there's two approaches to the paradigms of healthy aging. One is humanitarian medicine, which focuses on the direct and obvious paths to ameliorating human suffering, it says here, but health and well-being, promoting health and well-being. So we've got exercise, we've got connection, we've got mobility, we've got more exercise, we've got more mobility. So all of these things, including access to the internet and looking at behavior and living conditions and all of these things, and combating racism. That's all part of that. But then the other part is around the health in late life. So this comes to the health span part. So this is the geroscience thing that I talked about right in the very beginning. And this is maintaining health as long as possible through the lifespan, and basically understanding that along with all of the interventions. So the interventions are huge and great and promote healthy aging, but we also have to couple that with an understanding of the aging process so we can increase the health span. So I'm going to stop there. I can provide the slides so you can have them to look at afterwards. There's a number of ways that you can follow the work that we're doing at the CIHR Institute of Aging. We have a newsletter you can sign up for. I'm on Twitter, and we have a website. And thank you very much.